Topic for today's presentation: ischemic heart disease. Ischemic heart disease is characterized by myocardial impairment, which is because of imbalance between the coronary artery blood flow and the myocardial requirement. The commonest cause is atherosclerotic coronary artery disease, but there can be other causes, but they are very rare and include coronary spasm, as seen in prismatic angina, coronary artery embolism, coronary arteritis, as seen in polyarteritis nodosa, Takayasu disease, SLE, etc. Can be seen with cocaine abuse, and also there can be spontaneous dissection of coronary arteries leading to IHD event. This is a diagram showing the various coronary arteries of the heart, the anterior view, aorta and the right coronary, left coronary dividing into left anterior descending branch and the circumflex. Coming to magnitude of the problem, cardiovascular diseases, they account for approximately 12 million deaths annually, and this is the commonest cause of death globally. There is a considerable decline in CVD diseases in the industrialized Western world. However, there are epidemics in the developing world. Asian Indians, particularly, whether living in their own country or anywhere else, they have much higher incidence of CAD when compared to all other ethnic groups. While the incidence of CAD has reduced by 50% in the West, in India it has doubled in the last 25 years. So we have to be very vigilant and to solve and halt this problem. Risk factors for clinical atherosclerosis. There can be various risk factors. Some of them can be modified, and while some can be non-modifiable. Among the non-modifiable risk factors, age. As we all know, increasing age, risk increases. More risk in male gender. More risk if there is a positive family history of CHD, or there is presence of CHD in menopausal females, and presence of physical inactivity because of various causes. All these are risk factors leading to coronary artery disease or because of atherosclerosis. Modified factors are dyslipidemia, hypertension, diabetes, abdominal obesity, smoking, and diet, mainly junk food, etc. These are few terms: asymptomatic, stable left angina, unstable angina. There can be non-Q wave MI, whether STEMI or non-STEMI. There can be Q wave MI. There can be sudden death, and there can be silent ischemia, which is nowadays called ischemic cardiomyopathy. Coming to the clinical presentation, the individual can present with a feeling of tightness or squeezing or heaviness. Sometimes they can feel this pressure. At times there can be burning, indigestion or aching sensation, which can be confused with GI disorders, dyspepsia. It is really typical pain, but rather most of the time it is some squeezing or tightness type of sensation. It is not a sharp, stabbing, prickly, spasmodic or pleuritic pain. It is a diffuse heaviness is there, and it lasts less than 10 minutes and relieved by sublingual nitroglycerin. Levine sign: the patient usually they with very much tightness and squeezing when they is there, they clench fist to sternum. So this is very typical of myocardial ischemic pain, vaginal pain. Few other differentiating features between ischemic cardiac pain and non-cardiac pain is that the location. Ischemic chest pain, cardiac chest pain is usually central and diffuse, while the non-cardiac is usually peripheral and localized. So when the pain is localized, there is more chances that it is a non-cardiac chest pain. Radiation, non-cardiac chest pain, often there is no radiation, but in cardiac chest pain, the pain can radiate to jaw, neck, the shoulders, the arm, and occasionally, sometimes, it can radiate to back also. The character of the pain, as we have discussed, is tight, squeezing type of pain. There can be choking sensation. While non-cardiac chest pains are sharp, stabbing, catching, etc. When these features are there, it is less likely that it is a cardiac chest pain. Precipitation that is aggravated by exercise or emotion or exertion is a cardiac chest pain. While the non-cardiac chest pain, they can be spontaneous and they might not be related with any exertion. Relieving factors, cardiac chest pain gets relieved on rest, and there is a very quick response to nitrates, while non-cardiac chest pain need not necessarily relieved by rest, and there is no response to nitrates usually. Associated features, they can be breathlessness along with cardiac chest pain, while there can be many other symptoms when there is non-cardiac chest pain, depending on what is the cause of the chest pain. Like respiratory symptoms can be there, gastrointestinal symptoms can be there, psychological features can be there, locomotor systems can be there in case of non-cardiac chest pain. Physical examination in this atherosclerosis, the various features we can see on general examination is presence of arcus senilis, it can be xanthomas. On fundoscopic examination, there can be AV nicking, exudates can be seen. Cardiovascular examination is usually normal unless there are signs of failure, etc. On auscultation, the carotid and peripheral arteries and abdomen may get some bruit or aortic aneurysm features can be there. Then on auscultation, cardiac auscultation, S4 is common in coronary artery disease. They can be tachycardia, they can be high blood pressure also. Coming to diagnostic tests, plus tests include serum lipids, fasting blood sugar, hematocrit, and thyroid function should be done. Especially anemias and hyperthyroidism, they can exacerbate myocardial ischemia. So these tests will be done. Resting ECG, because CAD patient, they have normal baseline ECGs in 90%. If there are pathological Q waves suggest previous infarction, minor ST wave abnormalities, they are not specific for CAD. Electrocardiogram, when ischemia results in transient horizontal or downsloping ST signals, or T wave inversion, which normalizes after pain resolution. So this is a transient ischemia. ST elevation suggests severe transmural ischemia or coronary artery spasm, which is less often. The spasm is less often. Other tests are exercise stress testing, stress perfusion imaging, and myocardial cellular metabolism assessment, echocardiography and stress echocardiography in CAD patient, ambulatory echocardiographic monitoring, coronary angiography, then various cardiac biomarkers can be sent for, then multi-slice CT coronary angiogram can be done, which is non-invasive investigation. Coming to management, the goals of treatment are to improve the quality of life, reduce the incidence of unstable angina and MI in these patients of atherosclerosis, to decrease the frequency and severity of anginal episodes, and to improve the longevity. So this is a chart showing that the approach should be that initially risk stratification should be done with stress testing, imaging, and LV systolic function assessment. In patients with low risk, that is small perfusion defects, small wall motion abnormalities on echo, high ischemia threshold, normal LV function, these all can be seen in echo and other in stress echocardiography, etc. And here we start with medical management. If after this the symptoms persist despite the optimal anti-anginal therapy, and there are multiple segment perfusion defects, or the ischemic threshold is very low and moderate LV dysfunction is there, we go for coronary angiography. Either they can be single vessel disease or multiple vessel disease. Medical manage, according to that we will decide. If in single vessel disease, usually along with the medical management, angioplasty is preferred, and while multiple vessel disease, depending on the extent, we can go for either PTCA or CABG. So medical management plus the management of risk factors. If there is no response, we go for PTCA. In cases of proximal LAD, if there is suspicion of proximal LAD involvement, then we go for PTCA, CABG. Left vein disease or plus LV dysfunction, we go for CABG. And viability assessment, then PTCA or CABG. Methods of treatment of CAD. Lifestyle modification, as very important it is in all the chronic diseases. So no smoking, weight has to be lowered, control the hypertension and diabetes if present. Coming to pharmacological treatment, there can be antiplatelets, lipid lowering agents, nitrates, beta blockers, calcium channel blockers. Along with this, adjunctive treatments are metabolic modulation, pyrimethamine, LV dysfunction if there is present, then ACE inhibitors and aldosterone antagonists. There is a role of gene therapy and stem cell therapy also. Then in more severe diseases, percutaneous coronary interventions can be required, and later surgical revascularization. Need for surgical treatment can be there. Now coming to pharmacological therapy in details, the therapy is aimed in restoring the balance between the myocardial oxygen supply and the myocardial oxygen demand. Here the useful agents are nitrates, beta blockers and calcium channel blockers. Nitrates, they reduce the myocardial oxygen demand, relax the vascular smooth muscles, reduce the venous return to heart, and they are arteriolar dilators, decrease the resistance against which left ventricle contracts and reduces wall tension and oxygen demand. So they are basically mainly reducing the preload, but also as they are arteriolar dilators, they decrease the resistance against which left ventricle is contracting, so the afterload also. Beta blockers, they prevent effort-induced angina, they decrease mortality after myocardial infarction, and they mainly reduce the myocardial oxygen demand by slowing the heart rate. Also, they reduce the force of ventricular contraction and decrease the blood pressure. Side effects of beta blockers are bronchospasm. They can precipitate congestive heart failure if the LV function is grossly impaired. They can be depression, they can be sexual dysfunction, sometimes they can be AV blockage, exacerbation of fluidification in peripheral vascular diseases. They can be potential masking of hypoglycemia in diabetic patients. So beta blockers should be very carefully given and monitored when being given in such patients, or we should use particular selective beta blockers. Abrupt cessation of beta blockers can cause tachycardia. Also there can be angina or MI, and so the abrupt cessation should be avoided. Calcium channel blockers. They are anti-anginal agents, prevent angina. Episodes of coronary vasospasm, here there are these calcium channel blockers are very helpful. They decreases the myocardial oxygen requirements and increase the myocardial oxygen supply. They are potent arterial vasodilators, so they decrease the systemic vascular resistance, they decrease the blood pressure. Along with that, they decrease the left ventricular wall stress and hence decrease the myocardial oxygen consumption. Calcium channel blockers are secondary agents in the management of stable angina and are prescribed only after beta blockers and nitrate therapy has already been considered. A potential to adversely decrease left ventricular contractility. So before starting, always we should get an echo done, and if there is severe LV impairment, LV function impairment, we should avoid calcium channel blockers. Acute coronary syndrome. The term acute coronary syndrome refers to any group of clinical symptoms compatible with acute myocardial ischemia and covers the spectrum of clinical conditions ranging from unstable angina to non-ST segment elevation myocardial infarction and ST segment elevation myocardial infarction.